All right, similar kind of story. 2-year-old male again. We're going to take away the coughing this time. So 4 days of vomiting and fever. And they're visiting here from Colombia. They live in Colombia, but they flew up here to visit relatives. And they come in looking like this. And they have some petechiae. They're currently febrile. And they're tachycardic. And they're hypotensive. And their SAT is 96% on room air. So, team, tell me what view and what findings. Awesome. Subxiphoid view, no effusion. Yeah, nice little clip there. This is our ex-fellow Jade Seguin, who is doing a kind of beautiful, hey, I've got 6 seconds of video and I can show you 2 views in that time, which is nice. So she's switching between a parasternal long and a parasternal short. What does the function seem to you? Okay, and then, yeah, there are some B lines arising from the pleural surface that abuts the heart. And in the parasternal short, what do we use the parasternal short for? What does it tell us? Functions 1. Right-sided pressures are another. And then if you were treating adults, right-sided pressures, yeah. Yeah, and Greg says it can tell you which vessel is causing their heart attack. So regional wall motion, anomaly. So one part of the wall is not squeezing. You can map that back to vessels. All right, and then here's our IVC view. This is a patient who's gotten 3 boluses over the course of their stay, and their hypotension is not resolved, and this is their IVC view. So tell me the different things you see. Do you see the IVC?
Yeah, but
right.
I would say like on the pleural side.
It's not collapsing.
Not collapsing, let's say.
This guy here, hey? Yeah. Big?
Yeah. I would say decent.
You think it's plethoric?
It's not collapse. Let's say that. Okay. But that's plethoric. Something.
Okay. Is there anything else to see in this shot?
We don't see the hepatic.
You don't see the
Dilated hepatic vein or something?
Oh, I'm realizing the lighting in here is not the greatest. Let me turn down the other one.
And we see a spine side.
So, spine side. So what does that tell you?
Some kind of pleural effusion.
Yeah, we've got a pleural effusion. And we're over the IVC, so we're probably slightly to the right side, so it's probably a right-sided pleural effusion. Okay, so then this patient who's gotten a number of boluses has a non-plethoric IVC and a pleural effusion. So what do you guys start to think about causes of this picture? Capillary leak, I hear. Yeah, good. So now we're going to do that thinking shift from diagnostic to therapeutic. Good. So maybe this is a kid I need to switch to pressors, right? They're still shocked. They've gotten 3 boluses. Why can't we give another? Maybe we can't give another because it's just going to accumulate in their chest. And so we'll just, verify. We'll do that. Look at their a more traditional kind of view for looking at their pleural effusion. So walk me through what you're seeing.
See the spine side. See the lungs in the low, they're swimming.
Anything else? Watch my cursor.
For a second, maybe there's some like little bit of that.
Yeah, right. Maybe. I'm not sure it's definitive, but it's enough for me to think about. Does that change anything for you? Do you think this patient now has had abdominal trauma?
No.
We'd think they'd probably have capillary leak, right? So wouldn't be that surprising if we saw free fluid in the abdomen. Which, when you go scan their pelvis, everyone appreciates the behind the bladder, this bow tie-like appearance of free fluid. So a patient with shock appearance, sepsis appearance, coming from Colombia, they have petechiae, and it seems like they have fluid accumulating in free areas of their chest and abdomen. And just for completeness sake, I'm always going to say scan everything, make sure everything should fit. So you're scanning for a pneumothorax, because what if they have an obstructive cause? It's a tension pneumothorax, so you want to have a look with your linear probe on their anterior chest. And their sliding looks good. And we just want to make sure we understand what an effusion is going to look like. If it's large enough to move to the anterior chest, how it's going to look where you capture it there.
You see more pulmonary edema?
You may. It's variable, I'd say. Yeah. I would probably anticipate that this kid would have what you see here, which is they do have a number of B lines. You'll see them more near the end of the clip. A little shower B lines show up there. So not the kind of thing we see every day, and probably not important that we go, this is dengue hemorrhagic shock syndrome, which is what it was. But that we use that principle of when do I divert from fluids to pressors based on what I'm seeing in my ultrasound. Okay, next case. Back to the same kid. 2-year-old. This time he has not traveled here from Colombia. This time there's fever again. They're febrile in the ER, and they have that same vital pattern that I keep putting up. So, team, what view, what findings? Subxiphoid, perfect. A little bit of fluid I'm hearing, yep. So everyone's seeing that wedge there. Now, if this is the only view that you have, and let's say we give you more views, but they only reveal that fluid there, is that an effusion or is that physiologic fluid? Definitely can. So to be, people often, when they see fluid in one little pocket, they jump to calling it effusion. They use the terms interchangeably, but effusion is pathologic fluid. So I would keep my language. If this is all I had, I would say, I see a small wedge of pericardial fluid. And if someone pushes me on, is it effusion? I would say, I don't think so, based on what I see so far. This is the border of the right side of the heart. And to call it effusion, it gets simple. You can feel really confident about calling it effusion when you see it skirt to the left side. When it makes that corner around the apex, that's when most of us would say, like, I think this is an effusion and not just physiologic fluid.
The squeezing of the function.
Yeah. So you'll hear me preach. The best view for function is the parasternal long, but that doesn't mean you can't use other views to say, well, wait. So everyone was able on this subxiphoid view to identify the fact that they have suspicions about poor function.